The next presentation is Differences in Aortic Intramural Hematoma Contrast Attenuation on Multi-Phase CTA Predict Long-Term Aortic Morphologic Change by Charles DiCarlo and colleagues from Massachusetts General Hospital.
Thank you for the opportunity to present our work, and I have nothing to disclose. Acute aortic intramural hematoma is a complex clinical problem associated with a high rate of adverse events. However, the clinical course of acute IMH can vary widely, ranging from complete spontaneous resolution to progression to dissection, aneurysmal degeneration, and rupture, and identifying predictive factors for adverse events remains a challenge. One potential source of variability in clinical course is variability in IMH blood flow. Intimal defects may result in variable levels of false lumen flow. However, few studies have evaluated contrast enhancement of the hematoma as a predictor of adverse events in aortic growth in patients with IMH. As such, we sought to measure differences in IMH contrast attenuation between arterial and delayed phase and determine its association with long-term aortic growth and adverse events. We hypothesize that patients with greater contrast enhancement of the hematoma on delayed phase would be at higher risk for adverse events. We identified patients with IMH by searching radiology reports from the years 2005 to 2020, excluding patients with an isolated zone 0 IMH, associated aortic dissection, or iatrogenic IMH. Conversely, a patient with a type A IMH with distal extension that underwent proximal repair were included in this study. On the initial CTA, we measured the Hounsfield units of the IMH at its thickest portion on both arterial and delayed phase imaging at the same anatomic location. And we also measured the largest diameter of the IMH-affected aorta on all available CTAs. Here's an example of the mean Hounsfield units being measured. On the left side is a delayed phase axial image of the IMH at its largest thickness. An ellipse was used to sample the IMH, and the mean Hounsfield units within that ellipse was recorded. Similar measurements were obtained on the arterial phase images at the same anatomic location. From these measurements, we define the Hounsfield unit ratio, which is the mean Hounsfield unit of the IMH on delayed phase divided by the mean Hounsfield unit of the IMH on arterial phase. Thus, an increasing Hounsfield unit ratio was consistent with increased enhancement of the hematoma on delayed phase imaging. And our outcomes of interest were change in aortic diameter over time and adverse aortic events, which was the composite of intervention, recurrence of symptoms, progression to dissection, and rupture. This did not include interventions for zone 0 IMH. For statistical analysis, we used a linear mixed effects model to estimate the change in aortic diameter over time and the Hounsfield unit ratio's effect on it. Kaplan-Meier analysis estimated freedom from adverse aortic events, and the Cox proportional hazard model estimated the effect of the Hounsfield unit ratio on adverse aortic events. Overall, there were 73 patients with IMH, 8 who met exclusion criteria, and of the remaining 65, 27 had delayed phase imaging and served as the cohort for this analysis. In comparing patients who were included in this analysis and patients who were excluded for not having delayed phase imaging, the only differences were the patients that were included were more likely to have hypertension, more likely to be smokers, and more likely to have coronary artery disease. Age, demographics, and other comorbidities were similar between the two groups. The mean age of our cohort was 72 years, and 56% of patients were female. 100% had hypertension, and coronary artery disease and hyperlipidemia were also similar between the groups, or common within the cohort. The mean initial largest diameter of the IMH-affected aorta was 41 millimeters. The most common proximal extent was aortic zone 3, and the most common distal extent was aortic zone 5. There were 4 type A IMHs included in the study, and 56% of patients had an associated PAU or ulcer-like projection. This chart displays the Hounsfield unit ratio for each patient, with the x-axis, each tick representing a patient on the x-axis, and the y-axis corresponding to the value of the Hounsfield unit ratio. The mean Hounsfield unit ratio is 0.98 with a standard deviation of 0.3. The minimum value was 0.38 and the maximum was 1.9. For the linear mixed effects model, estimating the change in aortic diameter over time, the beta coefficient of time was negative 5.8 millimeters per year, which would correspond to the change in aortic diameter over time if the Hounsfield unit ratio was 0. The beta coefficient for the Hounsfield unit ratio was 5 millimeters per year per 1 unit Hounsfield unit ratio. In other words, a Hounsfield unit ratio greater than 1.15 was associated with aortic growth, while a Hounsfield unit ratio less than 1.15 was associated with a reduction in aortic diameter consistent with IMH resolution. 52% of patients had an adverse event, including 7 with symptom recurrence, 8 who underwent intervention, 1 who suffered rupture, and 5 that progressed to dissection. 8 patients had spontaneous resolution of the IMH. There was a trend towards increasing Hounsfield unit ratio being associated with increasing hazard of adverse aortic events. However, this did not reach statistical significance. The results of the study should be viewed in the context of limitations. First, our sample size was very small, precluding more sophisticated statistical analysis, such as multivariable modeling. Thus, it's difficult to know the significance of the Hounsfield unit ratio while taking into account other important variables. Second, we didn't utilize more advanced radiographic analysis techniques to measure the Hounsfield units throughout the entire IMH. Thus, our measurements might vary from the actual Hounsfield unit measurements of the entire IMH. Finally, Hounsfield unit ratio was measured once. It may have changed over time, but we did not account for this in our methods. In conclusion, increasing Hounsfield unit ratio was associated with a significantly increased aortic growth and a trend towards increasing adverse aortic events. Conversely, diminished delayed phase enhancement may predict partial or complete IMH resolution. Hounsfield unit ratio can be used to guide IMH surveillance and treatment and reaffirms the importance of multi-phase imaging in aortic pathology. Thank you.
Thank you for that talk, Dr. Lee.
Good morning. Really enjoyed that paper. Did you think about measuring at multiple sites along the descending thoracic aorta? I think finding a new ratio or defining a new parameter, it would be wonderful to know in the paper that, because there's only 27 patients. You just go back and you measure at the subclavian, 3 centimeters from the subclavian, halfway down at the celiac. And then I think you might find something that is starting to trend towards maybe this parameter can be added to the high-risk features that tend for us to think that maybe we should be more aggressive with TVAR.
So thank you for that point. That's an excellent point. And we did try to do that, but we found that it was rather difficult. Each IMH is going to have a thickest portion, but because each IMH, has a different proximal and distal extent, the question becomes like, well, where do you measure it for, IMHs that start mid-descending thoracic aorta and go down to the bifurcation versus, more proximal ones. So it's difficult to choose exactly where, set a standardized point to measure it. But I think, it's something we'll talk about in the paper for sure, and something that maybe deserves a little bit more investigation.
Go ahead.
Thank you. Great presentation. So we've always thought that the association of PAUs with IMHs make it not as benign as we thought it was going to be. So were you able to find an increase in your Hounsfield unit ratios in patients with PAUs? And if so, are you just kind of saying this same thing that we've always known about, which is PAUs make it a malignant condition?
Yeah, so when we were measuring the Hounsfield unit ratios in the IMH itself, we specifically avoided measuring it at the portion where there is a PAU, because of course that would increase the average Hounsfield units significantly. We didn't specifically look at the association between the measured Hounsfield units and whether or not the patient had a PAU, but that's certainly something we can look into. In the sort of larger cohort, not in this study, our results do affirm that patients who have an intramural hematoma and a PAU or ulcer-like projection have the worst outcomes.
Dr. McGee.
Hey, excellent presentation. Very interesting. I'm kind of confused, though. What exactly do you think is going on here that's leading to a change in the contrast attenuation in the hematoma? Is this just a proxy for flow versus no flow. And I wonder if that's actually maybe more relevant. I can imagine why, I mean, just looking at the CAT scan you had, it looked like there was some turbulent flow within that IMH. So that would be a little more scary looking. And I can see how that would maybe lead to an increased attenuation in the venous phase, but how does there a decreased attenuation in the venous phase? That doesn't really make a lot of sense to me. And then, you know, does this change over time? I mean, you mentioned that having more flow or having higher ratio led to more growth, but at a follow-up scan, if there's a change in that ratio, does that lead to a change in the future growth?
So to answer your second question first, that's we didn't look at the change in the Hounsfield units over time and how that is associated with outcomes. We wanted to say, you know, this is our initial CT. We can potentially predict, you know, is this patient going to go towards spontaneous resolution or going to have an adverse event? But it's something that we should, you know, potentially look into in the future, the change in Hounsfield units over time. The first question was essentially why
What's going on with these hematomas? Like, how do you explain changes in the contrast attenuation?
Yeah, I mean, so the contrast attenuation is, you know, they're very small differences. You know, it's not like someone has, you know, a wide open false lumen on delayed phase versus, you know, a thrombosed false lumen. There are small differences. I don't have a great answer for it. It might be like minimal flow through the false lumen, and this may represent a more unstable thrombus, and that may lead to more adverse events compared to someone who has, you know, less flow on delayed phase imaging, which, you know, may represent a more stable thrombus. So, you know, contrast is just washing through faster and not, you know, going into the false lumen, but it's difficult to say for sure.
Just a quick point of clarification. These were all acute IMH?
Yes.
Last question, Dr. Kashyap.
Yeah, hi, Vic Kashyap from Cleveland. Very nice presentation, but I agree with the last commenter. I mean, you're getting just one picture in time, right? We don't know anything about what happens or how this evolves. And my question for you, just biologically, is this really IMH in those very high ratios, or is this a dissection where you just are not seeing the entry tear, and is that why those patients had worse outcomes? Thank you.
Yeah, I mean, that's a great point. I think, you know, all of these, you know, appeared like IMHs. So, you know, increased density compared to the aortic lumen on non-contrast. So it's not like any of these patients had like a patent false lumen that we could see either on arterial or delayed phase. It's just the small difference in Hounsfield units that's being measured on the delayed phase of the hematoma. Thank you.
Thank you.